Pena, Professor of Medicine at Thomas Jefferson University, and I would like to introduce our panel. Javed?
Hello. Hi, Ileana. Good to be here with you. I am Dr. Javed Butler. I serve as a president of the Baylor Scott and White Research Institute in Dallas, Texas, and as Distinguished Professor of Medicine at University of Mississippi in Jackson, Mississippi.
Hi, Ileana, and good to see you, Javed, as well. Rob Mentz, a heart failure cardiologist and trialist at Duke, where I'm the chief of heart failure. Really looking forward to this discussion.
Thank you, guys. So in this activity, we're going to review 3 patients with heart failure and iron deficiency, with or without anemia. So we think this will be a very practical session. We will discuss the missteps in care, how to improve practice and patient outcomes, as well as the most up-to-date guidelines, now that we have new guidelines for heart failure, for the management of these patients with heart failure and iron deficiency, with or without anemia. Dr. Butler, how about you start with our first case?
Absolutely delighted to. So let me present a case, a very common case, really no fascinoma, but just a sort of a case we see quite frequently and perhaps miss. So this is a 72-year-old patient with heart failure with reduced ejection fraction, last EF about 35%, really symptomatic class 3, has history of hypertension and diabetes, has been having recurrent heart failure hospitalizations for decompensation. If you look at a medical therapy, on pretty good medical therapy, maybe not on optimal doses of valsartan sacubitril, but her blood pressure is low. And in the past, when it was tried to go up on the doses, she really didn't do well. Heart rate is at target. And then we see her labs here, sodium 138, potassium 4.1. Her creatinine is 1.1, hemoglobin is 15. So far, just looks like a heart failure patient who is getting sick and getting into recurrent problems. So what are some of the other things to think about? I don't have it here. We checked the thyroid function test, that was normal. And then we checked her iron indices, and ferritin was 172 and transferrin was 17 on this patient. So the question is, in this patient who seems to have iron deficiency, but is really not anemic, is there any reason to worry about iron deficiency per se? So I have a few sort of questions to ask related to this patient's care. But before I go there, some of our friends and colleagues who are listening to this presentation may not think about iron metabolism all the time. So let me just give a very quick sort of a high-level primer. That the oral iron that we take gets absorbed in the gut and then gets transported by transferrin in the blood and is stored in hepatocytes and macrophages and reticuloendothelial system. So iron by itself has some toxic properties. So wherever iron is, it has to be combined with something. So if you were to give iron to the patients, iron is sort of combined with some sort of a transporter. And then in the blood, it is combined with transferrin, and in the cells, it is stored with ferritin. And the transport between inside and outside the cell occurs through this carrier called ferroportin that takes it from intracellular and brings it to the extracellular. So that is sort of the normal physiology. So a few questions. So for in this patient, maybe I can start with Rob. Maybe I can ask you this question. Patient has no anemia, recurrent heart failure, hospitalization symptoms, and seems to have iron deficiency. So 2 questions. Can you tell our audiences what is the definition of iron deficiency, at least from a treatment perspective? And do we worry about iron deficiency in non-anemic patients?
Sure. Thanks so much, Javed. I think a really nice case that illustrates some of the very common points. I think your first point is critical, really disconnecting anemia and iron deficiency. Iron deficiency very commonly occurs in patients regardless of anemia status. So really we need to think about iron deficiency regardless of what hemoglobin level is. That is a key take-home pearl for our listeners today. But then the second point, the specific definitions that we use for iron deficiency. It's ferritin less than 100 or a ferritin of 100 to 300 with a TSAT less than 20. And those are a lot of numbers to think of. So we've really got to have that framework in our mind where if it's a patient like this, if that ferritin is less than 100, that's a slam dunk. We need to be thinking about iron deficiency. But then remember that second piece. So if it's a ferritin of 1 to 300, then we look at the TSAT for less than 20. Those are two really critical points. Let's disconnect from anemia, focus on the iron deficiency, and then remember that definition so that we check this and can think about therapies.
So, Ileana, why are there two definitions? Why not just say ferritin less than 100 and that's it?
Well, I think that, we've been so accustomed to chasing quote unquote anemia, not realizing that there's this whole population of patients who in fact are iron deficient, but whose hemoglobin looks okay. Now, if you track those patients across time, eventually they'll become anemic. So it will happen at some point, but if you can catch it earlier, I would think that would be very beneficial to the patient to pick it up earlier.
Yeah, no, completely agree. So, to that point, so ferritin is an acute phase reactant, and when you have an inflammatory condition like heart failure, your ferritin levels may go up. So, so that may be sort of falsely high, if you may, because it's an acute phase reactant and you may miss iron deficiency. So that's why either you have an absolute reduction in ferritin levels less than 100, or if your ferritin level is high and you really don't know whether this is an acute phase reactant or is the person really iron replete, that's when you look at the iron saturation, transferrin saturation. If it's less than 20, that gives you a diagnosis of iron deficiency. So maybe I'll ask either one of you, again, pertinent to this case, that sort of strikes me a little bit something to discuss, and that is that hemoglobin is 15. So if somebody has iron deficiency anemia, I can understand you don't have oxygen carrying capacity, your muscles are tired, your lung muscles, respiratory, skeletal muscles, you're tired, you're short of breath. But if you're not anemic, so why would iron deficiency be important to treat, and why would it lead to symptoms? Maybe Rob, you can give some opinion on that.
Sure. So I think you basically set up those earlier studies, AFFIRM-AHF, CONFIRM-AHF, AFFECT-AHF, that took that exact patient population. So again, patients with heart failure with reduced ejection fraction, regardless of anemia status, and really honed in on iron deficiency and showed that in a placebo-controlled trial, multiple trials as I've gone through, by giving IV iron improves functional status, quality of life, really helps patients feel better and function better. So I think really disconnecting it from the anemia piece is really important. And I know we'll get into some of the guideline updates that really help clarify this for the clinical community as well.
Yeah, and I think too, Javed, if the protocol that you use in your institution only checks transferrin or only checks ferritin and doesn't look at the TSAT, you may miss it. So you've got to make sure that you're looking at all three items since you're going to stick the patient once, so you don't have to go back and, stick them again.
Yeah, I mean, I think there's a little bit of a clinician psychological issue here, is that we think about iron deficiency anemia so much that we forget that hemoglobin is not the only thing that requires iron in the body, right? So iron is part of so many enzymatic processes that are required for normal functioning of the body. The biggest one being obviously mitochondrial function. So, right, your ATP generation requires iron. So even if you do not have anemia, or maybe not anemia yet, and over time you might develop anemia, but if you are iron deficient, then your ATP production will go down, and that can lead to symptoms irrespective whether you have anemia or not. There are other enzymes, myoglobin function, whether it is related to soluble guanylate cyclase function and nitric oxide downstream signaling. All of these, there are multiple enzymes besides the hemoglobin level. So there is one issue is oxygen carrying capacity, but independent of oxygen carrying capacity, oxygen utilization and ATP production also require. So we really need to dissociate anemia and iron deficiency. And if you have iron deficiency in a heart failure patient, then treatment is maybe really necessary for symptomatic benefit. Ileana, let me just ask you, how common is iron deficiency? Are we making a big deal, and is it something very rare, or is it something really common and we just miss it?
I think it's more common than we realize. As we've been doing this now through the last few years, I've been looking more carefully at iron deficiency. Now the guidelines will tell us that as well. And I have found a lot of it, a lot more than I ever suspected, even without anemia. And I think if we put this patient of yours, for example, on the treadmill and try to do a cardiopulmonary test, I bet you anything her peak oxygen uptake is abnormal, significantly abnormal.
So Rob, you mentioned some about the benefits. So can you just sort of encapsulate in few words, what are the data out there for chronic outpatient heart failure patients benefiting from iron replacement if they have iron deficiency?
Great, thanks so much. So really the robust data we have is looking at IV ferric carboxymaltose in patients with heart failure and iron deficiency. And as I noted, those earlier studies, AFFIRM-AHF, CONFIRM-AHF, AFFECT-HF, they looked at several hundred patients with iron deficiency and heart failure, gave IV iron, and demonstrated improvements across the board in terms of 6-minute walk distance, patient-reported outcomes, really improving function and symptoms for these patients. And we'll talk in a few moments also about the acute heart failure space and some of the other more recent exciting data there as well, but really getting at the safety and efficacy to help patients feel better and improve their functional status.
And Ileana, how does that translate into guideline recommendation?
Well, I think we now have a class 1 recommendation to exactly look at those patients, do the iron studies, look at the hemoglobin. I am so used to hearing on rounds, our residents say, oh, a low hemoglobin, oh, that's part of the chronic disease picture. And I don't think that's the case, but that's been the common thinking. And then they don't pursue it, and the patient comes back in again with the same hemoglobin, and they call it chronic because it was there in the previous chart. Now, a class 2A recommendation, this time in the guidelines, is in fact IV iron supplementation with carboxymaltose, which Rob was just talking about, for patients, especially if they've been recently hospitalized and have HFrEF. And it gives the same parameters that we've been talking about, including the saturation below 200 if the ferritin is higher. And I think your point that ferritin is an acute inflammatory iron-containing substance would be elevated, particularly if the patients come in with a decompensation and these patients are sicker. And, for years we thought about, oh, what about erythropoietin? Well, that didn't work out too well. And now we have it as a class 3 not recommended to use any kind of erythropoietin type of drug.
Yeah, so there are so many other aspects to discuss, and we have 2 more cases to go. So let me just wrap this case by asking one last question to you, Rob. Your institution is doing some really cutting edge work in this aspect about population management and how we can use electronic health record and enhance that and leverage that for better care of patients. Can you just tell us a little bit if somebody were to improve detection of these patients who have already had documented iron deficiency or maybe should be evaluated for iron deficiency but is not being evaluated, and treatment? Like, how do we capture these patients who may benefit from this?
Great. So I think it's really emphasizing, just as Ileana said, we have guideline recommendations to check iron indices in these patients. When they're coming in, you're getting routine blood work to monitor their renal function and potassium. Make sure to include iron indices, follow up on them, and if meeting these criteria, think about IV iron and working through the logistics of your institution to help get these patients the therapy that is an important additional component on top of their other guideline-directed medical therapies.
I think it's something that we need to put into, especially the acute heart failure protocols, because you've got an opportunity, you have the patient right there. You have an opportunity to add the iron studies. We're all doing Chem7s and we're all doing CBCs. So why not add the iron studies at this point and get it as they're coming into, and then have the discussion with the patient. This is very important to talk to the patient about iron. It's a little bit easier because they've heard about iron with tired blood or weak blood, and they all have these commonplace definitions for low iron. So it's not that hard to get them to understand this.
Great. Ileana, maybe we can move on to the second case.
I'm going to wrap you up there, and we will move on then to, I have one question for Rob before we go any later. Would you give IV iron to this patient?
Absolutely. I think this is a great example where they're optimized to the extent possible on that quad therapy, the oral therapies. Let's add IV iron for this patient and do FCM in those 2 doses and help this patient feel better and function better.
I think toward the end of this session, I want to talk a little bit about where do we give the IV iron, because the place of that can be very difficult in some centers to get that done. So thank you, Javed. All right, so I have a case for you guys. This was a lady that I saw when I was in Detroit, 68-year-old lovely woman, Lucy, who had a diagnosis of HFrEF, not smoking, drank alcohol very rarely. She has a non-ischemic cardiomyopathy, and it's felt to be related to her many years of undertreated hypertension. She comes in with fatigue and dyspnea on exertion. And she says she's really trying to cut the salt in her meals. She wants to walk, but she's just exhausted. It's not short of breath that's limiting her. It's really just exhaustion. So her hypertension is old. It's been going on for 20 years, strong family history. And in my history of her, I got the point that when she had menopause, which started at about age 54, but we know that menopause is a process through time. It's not one day here and one day it's not. She had menorrhagia. And ever since then, she had been on iron capsules for her anemia because of the amount of blood that she had lost. You can see her medications. She could probably use a higher dose of the sacubitril/valsartan. I happen to like bisoprolol a lot, so she's on a small amount of bisoprolol. Spiro, she's been taking this iron sulfate forever. We already had started her on the dapagliflozin, and she's taking the torsemide as she needs it, basically because of her weights. So she was visibly pale and tired. She just looked tired. Her blood pressure is 90, which doesn't leave me a lot of room to go up on the sacubitril/valsartan. Normal sinus rhythm, afebrile. Her conjunctiva were very pale, and I think we forget to do that part of the physical exam to actually look at the eyes. Chest was clear. She had no murmurs. Her abdomen was fine. She had no edema. On echo, her EF was 25%. So I know you're going to ask me about her lab. So here they are. Her sodium is 138. Her K is a little elevated. Here's her hemoglobin, 10, which, again, if I'm making rounds, I often hear this said, oh, it's chronic. It was already there. White count 7,000. Her CRIT 30. Her creatinine 1.5, not totally normal, but hey, do we see a lot of people with normal kidneys? I don't think we do. The ferritin was 12, and the TSAT was 16. And so what would you do? Javed, let me ask you first. What would you do with her?
Yeah, so, from a diagnostic perspective, obviously, life becomes a little bit easier in this patient with a history of menorrhagia, but if not, if that history was not there, again, sort of the common sense things, this is non-ischemic, so, subclinical ischemia is unlikely. You would just think about usual things like hypothyroidism and any reason to believe that there is any pulmonary problem. And then very soon, iron deficiency would be in a differential diagnosis. But this person's history makes it iron deficiency way up on the list, and you have to then treat it. So one big question that comes up in a person like this is, if somebody's anemia is, significant, as anemia is 10. So first of all, again, I find it sort of pretty amazing how much of this is all psychological and clinicians, training and what lessons we learn. So hemoglobin of 10, I think most people would be uncomfortable and will react. But if hemoglobin was 11.5, you would just ignore, right? We will never sort of figure out what was the we would just sort of keep going and ignore. But in this case, obviously, you cannot. So the first question is, in the previous case, we discussed that in the absence of anemia, iron deficiency is important. But now the question is, if you do have anemia, does iron deficiency have any incremental prognostic value? And the answer is absolutely yes. We have seen this from multiple epidemiologic studies and other studies that patients who have neither iron deficiency nor anemia. If you develop iron deficiency, their functional capacity goes down, their symptoms get worse, their prognosis gets worse. But if you have both iron deficiency and anemia, there is an incrementally higher risk, incrementally worse symptoms, incrementally worse functional capacity in these patients. So these two are two separate diseases that have incrementally further worsening of outcomes, and one or the other does not lower the significance of the other disease. So this person, obviously, first of all, this person has severe iron deficiency, has a history, so the package is there. But suppose if that entire clinical history was not there, one of the things to think about is, what is the cause of anemia, and just make sure that you're not missing anything. And then if you have significant iron deficiency anemia, one thing you sort of always worry about in a person without this history is if they have like colon cancer or something else is going on and you just want to rule that out. But after, those sort of general medical evaluation consideration, this person has a very good chance of improving their symptom if her iron deficiency is treated. Iron deficiency will get treated and her anemia simultaneously will get better, and this person will likely be improved.
I think one point about this is the history taking. Woman with this much anemia at this age, already having gone to menopause, I think menorrhagia is pretty common. And if you don't ask that question, you will never know. So the patient's reproductive history all through life is very important. So if we want one clinical pearl here for our audience, you've got to ask the questions. In a male, the first thing that I would think of is colon cancer, actually. And we have seen patients that we've taken care of in clinic for a long time all of a sudden show up anemic. First question you ask them is, did you have a colonoscopy, and when was your last colonoscopy? And we have unfortunately picked up colon cancers like that too, that it happens very gradually and they become anemic very gradually. So it can never take the place of a good history. Rob, do you want to make any comments about this case?
Sure. So I think you all summarized the key considerations. We focused a good bit on the iron deficiency piece in that first case, and now we're really honing in on those that also may have anemia. We have to rule out other etiologies. It just cannot be chalked up to heart failure alone. We need to make sure it's not related to GI bleeding or other blood loss, as you note. And we need to also, she has underlying renal dysfunction as well, understanding the cardiorenal axis here and how that plays in with EPO. But you're exactly right. We need to understand and rule out some of these other etiologies. You noted the contraindication or the class 3 recommendation to not give EPO, right? So once we've ruled out other sources of bleeding, not giving EPO, but thinking about iron deficiency is the primary underlying etiology for their low low hemoglobin here as well.
And her symptoms made a lot of sense to me because we do have data from cardiopulmonary testing that the patients who have low iron and anemia definitely have an impaired peak VO2. And if they could get replenished, that peak VO2 gets better. And it really doesn't matter if it's HFrEF or HFpEF, so that we need to look equally across the board at these patients, particularly with this history that she had, that she was just exhausted. It wasn't shortness of breath. It was tiredness, that fatigue.
Can I ask a question to both of you? So it's very interesting that both the cases we are discussing so far, Ileana, from your practice, and then I presented something from our side, these patients happen to be on really good, excellent baseline medical therapy, right? They were on quadruple therapy, but we know that that's nowhere close to what happens in real life practice. So we know that we emphasize foundational therapies first. We don't say that, go ahead and give, digoxin or ivabradine or CRT or ICD or whatever until you have given the foundational therapy and see how the person does better. Now, when it comes to iron deficiency, which is a whole pathophysiology by itself, it's not just a generic heart failure therapy. If these patients were to come to you and they're not on optimal therapy, would you replete iron simultaneously as you're optimizing therapy? Or are there any data, and let me start by saying, I don't know of any data, but maybe you're aware of any data, that good foundational guideline drives medical therapy will like automatically lead to iron stores getting repleted and you don't need iron repletion. So maybe Rob, you can comment, simultaneous or wait for quadruple therapy before giving iron replacement?
Yeah, so I think really the simultaneous approach is the way to go here, and a couple key reasons. What we know is that by doing IV iron for this patient, they're going to start to feel better, right? So in fairly short order, they'll be starting to feel better as you're adding these other therapies. So they'll become more active. You may even see some increases in their blood pressure and other aspects that could allow further use of some of the oral therapies that we'll talk about as well. So I think your point is spot on. Looking at the totality of evidence, I think really suggesting that even as we titrate oral therapies, we can think about IV iron at the same time. And for this patient, I think another key point is that she's been on oral iron for a long time and is still quite iron deficient. So pulling out this important point from the Iron Out study, we know that patients with heart failure and iron deficiency really do not absorb oral iron. It leads to constipation, other patients feeling uncomfortable with this without clear benefit. So I think a very important point is we look at the polypharmacy aspect, we can think, what can we deprescribe? Let's stop the oral iron and talk about IV iron. But Ileana, what would you add on the context of oral iron as you saw this patient in clinic?
I got rid of it. I got rid of it and got her on IV iron, and it was absolutely amazing. After her second dose, I sent her to where I was at the time. We had a very good infusion unit that was being used by oncology primarily, but I made arrangements with the nurses for her to go down there and get her shots. By the second one, she came up to clinic to tell me that she was walking, which was very important to her to be able to go around for her walks. And she was feeling so much incredibly better. The other thing to remember about the oral iron is that it can either give diarrhea or constipation, either or. And very often the patients will skip it because they realize that their gut doesn't feel right, so they don't take it. So it's not like they're probably taking it every single day. You have to assume that they're not. But to Javed's point, this is a conversation from the first time that you meet this patient and you're starting their drugs. And it's not a conversation you're going to get it done in 15 minutes and your hand is on the doorknob to get out of the room. You have to spend enough time to say to them, you're here, I'm going to increase your medications gradually, but I'm also going to look for anything else that could possibly making you feel not well, and impairing. And I send them all to walk. They have to walk for me 45 minutes to an hour every single day. So as I'm doing this, they're going to be able to walk better. And that rehab piece is really important.
So what you said is sort of so important, Ileana, and I just want to take 1 second to highlight this. It may sound like semantics, but this differentiation is really important. So when we give the foundational therapy and devices and second line therapy for heart failure, we are treating heart failure. But you specifically mentioned here, then you also need to look at other things that may make heart failure worse. And iron deficiency is a disease that makes heart failure worse and has to be treated. So we don't need to wait for other heart failure therapies, but iron deficiency, if a person has it, it needs to be treated simultaneously.
And I think the new guidelines have it very nicely set that in spite of everything that we do, so somewhere there in that fourth column, think of anything else that is going on with that patient, and includes, for example, sleep apnea. So look for any other condition that, as you said, is simultaneous, not directly related, but is impacting how the patients feel.
I mean, it's really akin to saying that if you diagnose somebody with heart failure who has significant hypothyroidism, you're not going to wait for heart failure therapies to treat hypothyroidism, right? So that's sort of an analogy, I think.
Right. And we've seen those too who are hypothyroid. Also, I think we do need to say that the IV is more expensive. And as we're talking about where do you do it, right now where I am at Thomas Jefferson, they haven't worked out a place to do it because they don't give IV diuretics in the office. So Rob, what are you guys doing at Duke? I mean, you've had a lot of IV therapy clinics that have been very successful.
Sure. So we have a model where we work closely with our infusion center. So we're able to do the laboratories to identify iron deficiency, and then schedule them in our infusion clinic. And I've actually reworded some of the language around this. Sometimes from a patient perspective, if you say we're sending you to the infusion center and they're seeing, being seen alongside patients getting chemotherapies, that can be, from a patient-centered perspective, a little bit overwhelming. So I describe this as an IV medicine that is really nicely able to complement their other oral therapies. And it's so nice in this case because it's not another pill they take every day. You can give this IV iron infusion, and we just do that. You try to do it actually the same day of an outpatient heart failure office visit.
And to make it as easy on the patients as possible. Rob, you have a case for us too. Why don't you start?
Great. So thanks so much. So this is a patient that I've followed actually for quite a long time now. We'll call him Jeff for this example, but he's a 67-year-old man, history of HFrEF, last EF of 25%, also has non-ischemic cardiomyopathy and underlying atrial fibrillation. He's actually now admitted with acute heart failure. So in contrast to the last two cases where we were focusing on the outpatient setting, now in the hospital, worsening shortness of breath, leg swelling, abdominal distension, and really short of breath with minimal exertion now. In terms of other features for this patient, he's married with children. He works as a teacher and as an athletic coach, does not smoke or drink alcohol, has a strong family history of heart failure as well. So we noted his permanent AFib that's underlying. He does have other important comorbidities, as we've discussed today, obesity, hypertension, and underlying renal dysfunction. Also on quad therapy, and we note here that medium dose of sacubitril/valsartan and a lower dose of long-acting metoprolol. So thinking of other optimization as we're able to based on blood pressure and heart rate. As we look at exam for this patient who's now in the hospital on our service, we can see blood pressure systolic of 114. He is obese, has evidence of congestion, so elevated JVP, bibasilar rales, and lower extremity edema. Key laboratory values here, underlying renal dysfunction, a creatinine of 1.8 with a GFR right around 40. We see his hemoglobin is normal as he's coming into the hospital. And we'll note some of his other testing demonstrating pulmonary edema. He is in atrial fibrillation with that heart rate in the 90s as we think about other medication titration like beta blockers. And when we get a repeat echo given as decompensation. But let's maybe take a deeper dive into what we did in terms of management for this patient. So we know the importance of decongestion and optimization of those oral therapies. So we worked on the decongestion aspect, titrated up his beta blocker, and over time, actually we're able to get him on the highest target dose of ARNI as well. And the question for our group is, what is the key next step? And this is actually now during the hospital stay. So our key point in the context of our discussion today is certainly thinking about iron deficiency, so checking those laboratory values and making that routine for these patients. And for this patient, his ferritin came back at 56. And as we took a deep dive into his chart, we could see that his iron indices had been tested months before by a different provider and actually not recognized. So the importance of, we can't just check these lab values, we must follow up on them. So I think this is just a really good example of thinking about that comorbidity management. And I'd like to pull in now and really focus on the updated guideline recommendations, because I think that this is such an important piece that helps us think through the underlying updates here. And this is really in the context of the most recent large IV iron study, AFFIRM-AHF, which was over 1,100 patients, stabilized, and importantly, ejection fraction in this example, it was actually EF less than 50. So it does include those mildly reduced ejection fraction patients. We have data in that space, giving IV iron during that follow-up of out to 24 weeks, and then a clinical outcomes through 52 weeks, and actually a clinical outcomes study here. So we haven't yet talked about the important data from AFFIRM-AHF, which I would summarize as saying for that primary endpoint of cardiovascular death in the total heart failure hospitalizations, we saw a nominal reduction in clinical events really driven by this heart failure hospitalization, and that benefit occurring fairly early. So the curve's really separating after 12 weeks. Not meeting, in this case, the nominal level of statistical significance, but importantly, as we look at the totality of the evidence with a pre-specified COVID-19 analysis, this trial was impacted by the pandemic. And in that pre-specified analysis showing this benefit and actually meeting a nominal level of statistical significance there. So a 21% relative risk reduction in that primary endpoint. And maybe in that context, Javed, it'd be great to get your thoughts as you reviewed and then kind of distilled the data from AFFIRM. How has this changed your practice and begun to be incorporated on the hospitalized patient side as well?
Yeah, so first a few sort of very quick generic comments. So again, just for our colleagues who don't think about heart failure and prognosis all the time, I mean, heart failure hospitalization, first of all of these things that we're talking about today, optimization of foundational therapy and figuring out other things that may be making heart failure worse, like iron deficiency, all of this should really be done in the outpatient setting so that you can prevent hospitalization in the first place. But please do realize that when somebody gets hospitalized, their fundamental trajectory of the disease, the natural history changes, and now they are at 2 to 3 times higher risk for mortality and recurrent hospitalization. So hospitalization is a really good time to just sit back and just relook at the whole case. Are there significant valvular disease, ischemic heart disease, other medications that are missing, atrial fibrillation, should this patient be ablated? I mean, there's a whole bunch of things. Look at the overall picture. Now, coming to the hospitalized patient, Dr. Pini already mentioned that, the prevalence of outpatient heart failure with reduced ejection fraction and iron deficiency is about, various studies, 35 to 50% rate. The in-hospital studies, because these patients tend to be sicker who get admitted, we're talking about patients meeting iron deficiency somewhere in the range of 75, 80%. So it's very, very common. And in the outpatient, not only did we see consistent benefit in terms of quality of life data, those were smaller studies, not powered for outcomes. But if you put all of those together in the outpatient meta-analysis, we already know that there was a reduction in hospitalization. And now this study further proves that these patients had risk for recurrent hospitalization by repleting iron, that their risk of rehospitalization goes down. So what you both mentioned, one, think about screening for these precipitants in the hospital setting, and especially leveraging the electronic health record to identify these patients will make it easier. And then finally, somebody's in the hospital, you already have an IV line placed. You don't need to send to an infusion center. You don't need to pick up the phone calls. And it's a whole lot easier to get it done in the hospital setting as well.
Yeah, Rob, I want to comment on this trial that the event rates were pretty high. And they're very similar to the Victoria trial in the 30s. And the mortality was higher than what we've seen, for example, in the Paradigm trial. So this was a sick group of patients, and I commend the group for doing the sensitivity analysis post-COVID because the effect is there still with very little variability. But I think to understand that these patients that come in are in trouble because these event rates are very high. In this case that you showed, it would be very surprising that I would think a clinician would say, oh, iron deficiency? No. They look okay. I mean, this is just all heart failure. So if you don't go looking for it, you're not going to find it. And, and you guys did look for it with this patient of yours. And maybe that good relationship that you've had with that patient helped, that you know that patient across time.
So can I ask a quick question to both of you? This is the third case we are discussing with HFrEF. Is iron deficiency an issue in HFpEF?
Oh, I think very much so, particularly since we're dealing with older women that may have had, especially the anemia, undetected or unpaid attention to, let's put it that way, and it becomes just part of their chronic, oh, this patient's obese, so they have diabetes, so they have hypertension, they're not eating as well, all these other excuses where, again, it's a simple blood test. This is not an invasive, problematic procedure. Get it, because it may have a lot to do with how fatigued these women particularly get.
I completely agree. We have 4 or 5 studies in the HFrEF space and the guidelines are there. That's why we're talking, but we really need now clinical trials in HFpEF as well.
I think it'll be time for that. Well, what did you do with Jeff, Rob?
This was a great example where we were fortunate to give IV iron in the hospital, and then importantly also follow up on iron indices down the road. So he did very well with the therapy, and we helped decongest him, get him on his other oral guideline-directed medical therapies, and is doing very well as we see him back in clinic at a 3-month interval at this point.
How many sessions did you give them of IV iron? Because that's something we have not really discussed.
That's a really good question. So he got his first dose of IV FCM in the hospital, and then at follow-up at that early post-discharge visit, we gave another dose at that point. And there are, importantly, other ongoing studies in this space, including the HFpEF study, which will give us a better sense of this longitudinal experience with looking every 6 months at repeat dosing and understanding iron indices. So I think there's still much to learn, both as Javed noted in the HFpEF space, but then also understanding the long-term trajectory and really the long-term clinical outcome benefits to complement what we saw in the AFFIRM-AHF trial.
And I think to our audience, when you make up your mind that you are going to look for iron deficiency, as per the guidelines, that you think ahead. If you do decide to give IV iron, that you have a plan of how you're going to do it that is acceptable to your whole clinical group, whether you do it in an IV infusion clinic and have a good relationship with them, or whether you already give IV diuretics, for example, in your office, or whether there's an observation unit. So finding the place where the patient is the most comfortable and acceptance of this, because this is different than what we've been doing, and I just had 2 or 3 patients this week that I've had these conversations with, because I'm planning on giving them IV iron because I've got their drugs probably at the right place. And if you look at those AFFIRM curves, Rob, they break up at about 12 weeks, which is about the time that I'm starting to feel comfortable that I've given all the drugs, that I've got people optimized as best I can, as best as, their physiology allows me. So it's about the right time. Guys, I'm going to close off this discussion. This has been wonderful to be with the 2 of you and hearing these interesting cases, and it concludes our discussion. I would like to thank you because your insights and having your own perspectives in your clinic is so valuable, and thank you for participating in this activity. Please be sure to complete the post-test and evaluation form for your credits. We do look at these evaluations, and we'll add other programs if we think that they're badly needed.